Another pharmacist intervention, I had an elderly patient, or I don't know what you classify as elderly, but I would say 65 and older is kind of like getting there to where you need to start like adjusting medications and doses. But I had a patient, she's in her late 60s, she's picking up Xanax for the first time. And she was given 60 tablets, so she was automatically scheduled on it twice a day for anxiety. So I had the benzo discussion with her. I talked about poor efficacy for anxiety long-term with scheduled benzo usage. Talked about cognitive decline and then also risk of dementia with continued long-term usage. I talked about tolerance, and I talked about abuse potential and withdrawal with benzos. And then I also talked about the risk of falls and dizziness, particularly in older patients. So, older patients you don't really want on benzos or like Z drugs or anything like that that'll make them like dizzy or have a tendency to accumulate if their renal function or kidney function is declining because they're going to fall and break a bone. That increases risk for mortality. And then last but not least, I had a patient today actually pick up warfarin 5 milligrams, and it was flagging against Lovenox. So I assumed it was a bridge. A bridge meaning like it takes about 5 days for warfarin to become effective. Like if you have surgery, they'll take patients off of the warfarin and then bridge them with Lovenox. So we'll have like when they're coming back on the blood thinner, they'll have the Lovenox in their system like working as the anticoagulant or the blood thinner. And then we'll have the warfarin on top, and then we'll discontinue, like we'll stop the Lovenox about like 5 days in, because that's about when that warfarin's effective. So I noticed that the Lovenox was a treatment dose, and it wasn't a preventative dose. I didn't have a diagnosis for a blood clot on file. All I had was that the patient had a prosthetic valve, and the patient reported AFib as well. And I noticed the patient had been on the Lovenox for a few weeks at that point, and then was also on the warfarin. So I pointed that out, and the patient wasn't really responsive to what I was saying. She didn't like that I was questioning her medications, and she was a poor historian as well. I saw that she was also on amiodarone potentially, which is a rhythm control medication. It's for AFib. Not all AFib patients need rhythm control. They need rate control like a beta blocker, but not all patients need rhythm control. But the amiodarone also interacts with the warfarin. It's part of the Fab4 is what we call it. So fluconazole, amiodarone, Bactrim, and Flagyl, those are the 4 that are 2C9 inhibitors that can increase the concentrations of the warfarin and increase risk for bleeds. So not only was she on the treatment dose of the Lovenox and on 2 blood thinners and then on something that interacted, that was very concerning for me. So I ended up calling the office and I was on hold for like 20 minutes with a representative, and then I asked like a couple times, like, can I talk to the provider directly? And they said no, basically leave a message. So I left a message, so I'm hoping for them to call me back at some point.